Thank you very much. Thank you, June, for organising today and for inviting me to speak. I apologise in advance for any overlap with the previous speaker. I'd like to echo many comments that Brian mentioned about her. I'd also like to say that the medical community are very blessed that she is working with us. I apologise in advance for overlap with Eileen, but sometimes overlap is good because it emphasises important points. I want to talk about three things today: treatment for the present, treatment for the near future, and treatment for the future. When we think of ovarian cancer, it has to start somewhere, and it starts in the ovary, but it may also start in the fallopian tube. And depending on what genetic changes occur with it, it can go into an aggressive tumour or a more low-grade tumour. And this is called a tumour of low malignant potential. They tend to be spread like ovarian cancer through the abdomen. They're not sensitive to chemotherapy, and surgery is the most important treatment for them. And they have a course lasting for several years. But both this tumour, this rarer tumour and this more common tumour spread into the tummy, into the fat pad in the centre of the tummy and along the bowel. And that's where the symptoms come from. As Eileen has emphasised, these are silent areas, and that's a problem with this disease, which Matt will talk about after the coffee break, is that often they have spread extensively before we pick them up. And how they present, and it's sometimes fortunately it can be an accidental pickup, a cyst involving the ovary for a scan done for some other purpose. It can present with tummy symptoms because the bowel here is affected by it, so it presents with constipation or diarrhea. It can present with a swollen abdomen where fluid leaks out from these tumours in the tummy and cause abdominal distension. Sometimes the lymph glands that Eileen pointed out can be involved, so you can get back pain. There can also be bleeding if the tumour involves the womb or fallopian tube, shortness of breath if the tumour has spread to involve the lung, and then more generalised symptoms, weight loss because the tummy feels full, so there's a lack of interest in eating, and tiredness, which is a common symptom of cancers. So what to do? Well, the initial treatment is to obtain a diagnosis, and because the type of cancer this is will determine a huge amount of what the treatment follows subsequently. And a lot of things can cause the tummy symptoms that we're talking about. Cancer of the bowel can cause it, a variety of other non-cancerous conditions as well. So often the first point of our treatment is to get a diagnosis. That's usually from a biopsy. And then the issue is whether to do early surgery or late surgery. And then where does chemo fit in, and what happens when cancer returns. Surgery is the seminal part of management of this disease, and the surgery has been recognised as an important aspect of cancer care since 1934 for this condition. And surgery is important because the more of the cancer that is removed, the longer the survival for the patient. So a pivotal thing here is who operates on you and how successful that surgery is. So that's why these operations are specialist. And we know from studies done worldwide that the more specialist the surgeon is, the better the outcome for each group of surgeons that operates on you. The more specialist they are, the outcome year on year increases. And it isn't just for the first year, but it continues for up to a decade after the surgery is performed. Sometimes the tumour is too big to operate on initially, and we give chemotherapy first to make it smaller so that surgery can then be planned, and then surgery follows as part of the care. This is why surgery is important. These lines represent time after surgery and the likelihood of the cancer staying away. So you can see that the blue line here is where nothing is visible after surgery, and then each further one then is the cancer less than a centimetre or, more than a centimetre or less than a centimetre. So you can see here that for all the time after surgery is performed, the outcome is better, survival is better, depending on the extent of initial surgery and how successful the initial surgery was. Where does chemo fit in? Well, surgery will get rid of some of the disease, but as you can see in the slides that are there, the tumour will come back in many cases after the surgery has been performed. So in the 1960s, they looked at giving chemotherapy after surgery with the view to mopping things up after surgery. And these chemotherapy was developed after the First World War when the mustard gas was used, And then it was developed by the Germans, and if you can't beat your enemy, you emulate them. So the Allies then took these drugs and developed them. And there was a troop ship accident in Italy, and the soldiers who survived developed bone marrow disorders, and then these drugs were developed for leukemia and lymphoma. And these were really effective drugs. This is a patient in the South Infirmary who has a lymphoma. You can see this lump involving their leg there. He's an 80-year-old man, and we gave him one of the chemotherapy drugs related to nitrogen mustard from the First World War, and 10 days later the lump had gone completely. And these drugs then evolved from leukemia therapy then into ovarian cancer treatment. And what was found was that these drugs were very effective. 80 to 90% of patients responded to chemotherapy with advanced disease, probably the highest response rate of any tumour we treat in medical oncology. But what about if the cancer has been removed completely? Like June mentioned, the cancer is gone. So why chemotherapy after surgery if everything is gone, or if the cancer is at a very early stage? Well, this is a large study where they looked at long-term follow-ups. You can see going out to 15 years after the diagnosis in patients with very early stage cancer. So it was removed completely, confined to the ovary or to the pelvis. And you can see the women who got the chemotherapy did much better than the women who didn't get the chemotherapy. And that benefit, the improvement in outcome, continues for 15 years after treatment. So this is called adjuvant chemotherapy, adjunctive to surgery, or in addition, helping surgery. And what we found is that all of the groups with the more sinister ovarian cancers here benefited from chemo. So if the more aggressive types of early stage disease benefit from chemotherapy, not just the more common, less virulent forms. So because of this, in patients with early stage disease, unless it's a very limited tumour, we tend to give chemotherapy for 6 sessions, about 4 months after surgery is performed. For women where we can't operate initially, we do it's called interval debulking surgery. So we establish a diagnosis at the multidisciplinary meeting, the case is discussed, and the consensus then is reached that if you give chemo first for a period of time, it'll make the tumour smaller, allow the patient to improve nutritionally, and then surgery is then performed. So this is called interval treatment. It makes it sometimes easier to do because there's less issues with wound healing because the patient is more vibrant. It's helpful for older patients where there may be other medical conditions that are ongoing, heart disease or chest disease, that you need to get under control before surgery is performed. But if you wait until they're under control and then do surgery and then try and do chemotherapy, you've missed the boat. It's also helpful where the tumour is unresectable initially, what we call fixed, where the surgeon makes a judgment that the tissue, he can't remove the organs because they're too embedded, and that if you get chemo, that shrinks down, and therefore it's more effective. There's a large study looking at whether it doesn't make a difference if you get surgery early or in the middle of treatment, and there's no difference in outcome between the two groups. This is a large international European coordinated study which shows a benefit. So in some women where the surgery is delayed, it doesn't affect their overall outcome long term. The important thing is they get adequate surgery by a specialist surgeon. What about chemo? Well, oncologists are notorious for large studies where we look at varieties of different chemotypes to see which one is better. And this is the ultimate study in gynecologic cancers, where they looked at 5 different forms of ovarian cancer treatment given for 8 sessions in this study. So in some of the arms, you got 2 drugs initially, and then they switched it to another different combination subsequently. So this is the gynecologic oncology group study. And what you can see is that there's no difference between the arms. So what this tells us is that there's a variety of different chemotherapy regimens that we can use for patients, and that would depend on other medical problems that they might have, how vibrant they are, issues maybe they can't tolerate some drugs. Does switching to another drug combination make a difference? No. So this is very reassuring to us that there are a variety of different treatment options for patients, particularly if we use a standard Taxol and carboplatin therapy, but some women can't tolerate that because of drug problems or bone marrow problems or allergies. So it's just to say that there are different options and they all have the same outcome, which is very reassuring. But what isn't reassuring is this slide is here. So you can see that we get initial benefit with treatment, but it curves off so that in the majority of these patients, the cancer comes back. So while this is very reassuring that these options are equivalent in terms of benefit, but it's far from ideal. The curve should go like that, like we showed you with the early stage patients, if these drugs are so effective, not fall off so that the cancer comes back for patients. So how can we do better? Well, many people have commented that the ovarian tumours tend to remain within the tummy cavity, so why don't you give chemo in the tummy cavity so that it's delivered directly beside where the tumour is, so that there's more penetration of drug into the area. And a large American study looked at this, where they took women with ovarian cancer, which was optimum, so very little disease left behind after surgery, so small nodules within the tummy cavity, and half of them got the regular treatment and half of them got chemotherapy into the tummy in addition to regular treatment. And what that study showed now is down here, the white ones. So you can see the people who got the chemo into the tummy did better than the people who didn't get chemo into the tummy. But logistically, this is quite difficult to do, and there are catheters and there's a learning curve. So while the study is positive, it hasn't been really largely embraced in the oncology community as a method of treating ovarian cancer. There's also concern that the study, while it was a positive study, wasn't as good as some of the other studies in this patient population. We would expect the outcome from patients with the disease that these women had to be up here instead of down here. So the concern is that the patients in the study didn't do as well as expected, and that's why the treatment looked better than anticipated. So the end result is that it hasn't been widely endorsed, or while the study is positive, it hasn't been embraced by the oncology community, and that may be short-sighted on our part. And I think it may be something that will be revisited in the future as a potential mechanism. Many people say, well, why do you stop at 6 sessions of treatment? Why not just continue on with treatment? And what I say to people is that, first of all, you need time off treatment, and that after 6 sessions, many people have problems with pins and needles in their hands and feet. Tiredness is a problem. Fatigue is a problem. Is a problem, and bone marrow reserve is also reduced from the treatment. So continue. The other analogy I have is like if you put weed killer on the lawn and you keep putting out the same weed killer, ultimately the weeds become resistant and the weeds start to grow. So you have all of the negative effect of the weed killer. In other words, you've got a lawn with no grass, no health in it, and the weeds are still thriving. So that's where the 6 sessions comes from. And in other previous studies, they've looked at 6 and 8 and 12 sessions and have found no difference. What if we gave a different drug, though, in what we call a maintenance program after the chemo is given? So you get the standard treatment up front, and then after that you switch to a different drug, maybe a tablet or something like that. Well, there's been numerous studies on this, 20 or 30 studies altogether, and none of them have shown a benefit. There's one study that shows a positive benefit, but all of the people ended up with significant pins and needles in their hands and feet afterwards. So you had patients where they were cancer-free but couldn't dress themselves because they couldn't button their clothes. So while the study was positive, it was positive for the statistician, but it was negative for the patients. So the bottom line is we don't do it. What about when cancer returns? And Eileen has touched on this, and the issue when cancer returns is that we are now dealing with a chronic disease, a bit like we treat blood pressure or heart disease or rheumatologic conditions in the community, that the disease is treatable but not beatable. And I think it's important it's difficult. We would find that Eileen has talked about people being diagnosed. I find that many of us find that when cancer comes back, it's worse. There's there's the lack of hope that comes with it, the despair, the fact that many patients have been around the block, they're aware, they've been in the day ward, they've seen other people being less fortunate. And unfortunately, in our society, good news is no news. And we have many patients who do very well and see us infrequently with metastatic disease, but your likelihood of meeting them in the ward is very low. I have a patient with metastatic breast cancer who I inherited when I came to Cork in 2000, and she's still on active treatment, and she had metastatic disease involving the liver at the time of presentation, and we're now 12 years into her illness. She comes to the clinic once every 6 months, so many of the patients who are less fortunate than her will never meet her, and my team will never meet her as well because she hardly comes to see us. So they don't see the good news story, but we tend to see the people who have difficulty and trouble. I have another patient with ovarian cancer who was diagnosed in 1999 and is still on active treatment with newer drugs and does well. But equally, my patients don't see her because she only comes every 6 months to every year to see us. So I think it's important not to lose hope in this scenario because treatments are evolving and we don't know how long the journey is going to be. But what we do know as a healthcare professionals is that quality of life on this journey is hugely important. Eileen had talked about monitoring the marker after treatment comes back, and there's a lot of debate about this at the moment because the study has shown that this isn't 100% effective. But many of us, you get regular follow-up to look for symptoms and surveillance of management, and also to get an idea and to try and help with side effects of treatment. I think the important thing when people are in follow-up is the reassurance that scans aren't done, but if symptoms are present, scans will be done. That it's not that we don't do scans. We don't do scans if there's no indication, but if there is an indication, then the scan needs to be done, as Eileen says, within days. When we treat people in follow-up, it's important to be at 2 stages, not to catch it too early, but also not to catch it too late, because then patients have symptoms and it's much more difficult to manage. So the important part is to catch them somewhere here, so that they're well enough to get treatment, and so that also similarly, like managing blood pressure, you don't wait for the stroke to happen. You prevent the stroke with treatment. You allow treatment to prevent symptoms from the disease. When cancer returns, there are a variety of different treatment options that are available. And so we basically go through different drug options at various stages, depending on the patient, their quality of life issues with them. Hair loss is a significant problem, so we try and use treatments to defer hair loss as long as possible. Sometimes there are residual side effects of initial treatment, which make using some drug groups more difficult. So it's a judgment call and a partnership that allows the correct sequence of drugs to be used. And there's no right sequence. There are a variety of options, and there are a sequence of options that are correct for different people. So this generally goes like this, where people are operated on initially, and the cancer returns, and then ultimately we give various sequences of treatment. And there are a variety of different treatment options that are available in this. And the important thing for patients is that this list here is growing. And I think one of the good things that would come out of today's meeting is involvement of your organisation with the clinical trials group, so that these options here can grow. Because I think that is where there's enormous potential for impact of your organisation on our patient care. Many people are concerned. Many people feel that without side effects of treatment, there's no gain. And this is a study in America where gynecologic oncologists give chemo in America, and medical oncologists do as well. And there's always, medical oncologists always feel they do things better than anybody else. All medical professionals feel they do it better than their other group, that we're the biggest voice in the room. And this is a sobering voice. Hopefully I'm not a sobering voice, but this is a sobering slide, because in the groups that were treated by the gynecologic oncologists, they had less side effects with treatment, they had less admissions with hospital, they had less aggressive therapy, but the outcome was exactly the same. So more horsepower and more pedal to the metal doesn't necessarily translate into better outcomes for patients. And I think that's very important to recognise in terms of our treatment. I think the other thing with our treatment is it's important to recognise that it's not just drugs. There's also the importance of palliative care. There's interventional radiology for draining of fluid and for putting in stents that, in case where the bowel is affected and narrowed, they can put in stents that prevent people needing surgery. They have an enormous role to play, and we're blessed with a very gifted radiologist, Micheál Murphy, in the South Infirmary, in terms of diagnosis and in terms of treatment. Interventional pain management are things like epidurals and pumps and nerve blocks that are used to help alleviate symptoms from disease, and also radiotherapy. Radiotherapy is very effective for where there's lumps that are symptomatic, causing, say, bleeding or blockage. And radiotherapy is 95% effective in women with ovarian cancer. Ovarian cancer is a radiosensitive disease, and I think this is a very important adjunct to our treatment in terms of symptom management. So one of the issues that comes up repeatedly and why we get involved in clinical trials is why can't we do better with treatment so that it's more effective and has less side effects? Well, one of the things is that where we grew up in chemotherapy stemmed from an accidental finding of in soldiers who took the drugs. But cancer is very sophisticated, much more sophisticated than an accidental observation on our part will allow. And ovarian cancer, all ovarian cancers aren't created equal. Some will grow during treatment, a small number. Some will come back very quickly after treatment, and some will come back very late after treatment, years after treatment. And each of these groups are different. They have different genetic makeups. And so it's clear that one drug won't treat all, and one drug won't work for all. Sorry. And in 2000, this paper came out looking at how we could look at cancer better, and it's called Hallmarks of Cancer in 2000, and it outlines why cancer is different. And the analogy here is Anglo-Irish Bank, okay? So if you think of a bank, it's insensitive to growth signals because there was no regulator at the time, and it has self-sufficiency in growth signals. It is an environment that allows it to develop. So this is the political environment that allowed sustained growth of the bank. It has limitless replicative potential, i.e. the developers were looking for enormous amounts of money from it. And it's the ability to spread to the financial markets in Germany and France, which is why they're so interested in us now. So each of these represents targets, however, for our treatments. And oftentimes, one of the important developments has been looking at blood vessels. A cancer, without a blood vessel, the cancer can't grow. And in order to develop, the cancer starts with very small blood vessels and then expands into others. What about looking at cutting off these blood vessels to see if that would improve the cancer? Well, we know that a drug called Avastin, which inhibits blood vessel formation, is effective in ovarian cancer. You can see this lump here in a patient with the disease, which had come back after initial therapy, has now responded. And what we found is that it's a very effective drug in women with ascites where there's fluid buildup. It kind of shrinks the fluid down, and often they will report within weeks that the fluid has got less. And it's effective in disease that works, it responds to chemo, and in disease that doesn't respond to chemotherapy. If it was effective in patients with advanced disease, what about early stage disease? Well, 2 studies came out last year, looking at that of incorporating this drug into standard therapy. And so what they did was they took women with getting Taxol and carboplatin with advanced disease, half got standard treatment and half got the drugs added to it. And what you can see here is that it improved things. It kept the cancer away for longer. You can see the people who got the treatment, it stayed away for them for longer. But the overall survival was similar between the groups, except for one group, the women where they were higher risk for the cancer coming back. And they were women who had advanced disease at presentation where the surgery couldn't remove the disease completely. So this is a practice-changing development, and we're looking at now incorporating this agent into initial therapy for women with advanced disease, where there's still residual disease left behind that the surgeon hasn't been able to eliminate completely. There are significant financial issues with this. There's enormous economic toxicity with it, so we're looking at the best way to have those resources to use the drug in the best way possible. One of the things in the studies is that the treatment stops after 15 months, but it may be better to continue the drug for longer after that, because when you stop at 15 months here, the line seems to go down at a much more quicker rate, whereas if we could keep it going for longer, it might keep the cancer away for longer. What about other things that can be done? Well, in cancers are aggressive because they have changes in their genetics, and light switches that are switched, should be switching on and switching off, are constantly switched on because of genetic damage to the cancer. And that's a good thing in that it allows us to target that change. So the issue is that you've got a gene that tells the cancer to keep dividing, and then you get a drug that switches off that pathway, and that leads to a response in the disease. Ultimately then the cancer is smart and it bypasses it, and the cancer comes back again. The biggest lesson for this is in melanoma, which has been very difficult to treat. And this is a patient with melanoma involving the skin. You can see multiple skin lesions here. And he started this drug, orally administered drug, because he had a specific genetic change in his melanoma. and the cancer resolved completely. And these often resolve within weeks on this drug. It's like switching off a light. Because the cancer is so sensitive to that genetic change, once you switch off that change, you deprive the cancer of a growth signal. So in ovarian cancer, we are still searching for that holy grail, that single mutation that you can find, that you can knock out, and then get all of this huge benefit for patient care. There's a big search for this, and this is from the Cancer Genome Atlas, where a collaborative group of investigators worldwide looking at genetic changes within ovarian cancer. And the important part about this is that it's identifying these genetic changes that may be pivotal driver mutations in the cancer, and then will identify those changes, and then drugs will then be developed to target these changes. And I want to talk about these changes here in genetic mutations that are a source of development at the moment. The slide of the Anglo-Irish Bank slide is 2000. This is 2011, the new hallmarks of cancer. And you can see that the 6 things that were there initially have now been expanded, which is good because it allows for more target development. I was going to analyse this in terms of Fianna Fáil, but my mother would slap me if I put Fianna Fáil on a slide. This is my Fianna Fáil slide. So it's why Bertie left Fianna Fáil, not because of honour and etc., but to join Westlife. They're reuniting. So the things that are important to everybody in this room is this new change, genetic instability and mutation. And this developing systems are altered, so they're more vulnerable. And so if we just take this chair, the chair you're on has 4 legs. Now, and those 4 legs are what in the cancer cell would be what keeps the cancer cell going. In women with genetic mutations in the BRCA mutation, which is associated with familial breast cancer and ovarian cancer, one of the legs is gone. So a bit like a 3-leg stool, it can still stay upright. And if we make a drug to target the remaining, the 3rd leg, the chair will collapse. And these drugs are called PARP inhibitors, and they prevent DNA repair. So you take them by mouth, and they bind they knock out the leg of the chair, so that when genetic damage then occurs to the cancer, it can't repair itself, so it falls apart. You don't need to give them with anything, you just give them on their own. And in a study in England, they compared it to chemotherapy, and you can see it's exactly the same as chemotherapy. In fact, they think in the study, they actually think in some subgroups of patients that it may be even more effective in some groups rather than others, in women with the BRCA2 mutation rather than the BRCA1 mutation. There's minimum side effects with this. And in the studies that have been done, they found that 66% of women responded to it in terms of clinical benefit. So that's where there's symptom benefit, falling markers, improvement in quality of life. Very favourable profile. So we're very enthusiastic about this group. But you could say, well, these mutations are only in a small number of women with ovarian cancer, so that's really rare. So how relevant is that to me? Well, it's very relevant to you because in this Genome Atlas study, they found that a lot more women have these genetic changes in their cancer in a non-hereditary way, so that the cancer has developed this vulnerability. You may not have it yourself leading to the cancer, but when the cancer develops, it acquires this vulnerability in about 50% of cases here. And in the studies that have been done in these women with non-hereditary cancer, you can see the majority of them respond as well. This is here, called a waterfall plot. Down is good, up means growth, but down is good. You can see the significant response rate. So there's a lot of interest and enthusiasm about this, and the ICORC are trying to get a study of this into Ireland, not just in patients with hereditary cancer, but where the cancer itself has these genetic mutations occurring. So research will change lives, but these studies are in England. What about Ireland? We have a clinical trials group, ICORC, and it has advanced cancer treatment significantly. 1,250 people enrolled in clinical trials in Ireland in 2011. So 5% of all people who are diagnosed with cancer in Ireland will be enrolled in clinical trials. We've been mandated by the Health Research Board to double that in the next 3 years. So the involvement of June and others like her in our clinical trials network is welcome. because that will allow us to have a voice in terms of making our trials more effective, more relevant to patients, and also that it will make it more important in our communities. And these are the groups, some of the groups that we work with from America and Europe. But the most important paper that has come out in cancer medicine is not a drug, not a gene, it's a way of doing things. And Eileen alluded to this in terms of the M word in Cork, Marymount. And in cancer care, there are two models of care. There's where we have oncology care looking and surgical and radiotherapy initially in treatment, and when that stops working, then we send the patients to palliative care. However, cancer is not a light switch, and people aren't light switches that turn on and off. And illness, as it develops, has more symptoms occurring with it, and that often we need overlap of care, dovetailing of care, rather than this convenient switch that occurs. But what if this care of combined care, do people do better with combined care than with this dichotomous care of one group first and then the second group afterwards? So the study was done in America, where they compared people with lung cancer. Half got combined care and half got one group after the other. And what they found was that people who got standard care had higher incidences of depression compared to people who got early symptom care. But the most surprising finding of this study was outcome. People live longer if they had the palliative care service involved in their care earlier. And this difference is bigger than any other difference I've shown you for surgery, for chemotherapy, for investigational treatment today. And so what this tells us is that people need to be looked after by teams, not by individuals. And that if they're looked after by teams, they do much better. Voltaire said, doctors are men who prescribe medications of which they know little to cure diseases of which they know less, in human beings of whom they know nothing. And that may be a bit harsh, as we say. But I think that organizations like yours can allow doctors to know more about the people that they're treating, but also not just us, but also the infrastructure in which care is delivered to make it more patient-friendly. I always find that if you go into a hotel like this, the first thing they're concerned about is the customer, and they're concerned about customer care and front of house and everything like that. And that in our health system, we don't have that. We don't have that, what's the front of house for the patient here? We have what's the front of house for the doctors or the nurses, but we don't have the front of house for the patient. And I think that if we could reverse that, we would do so much better. And some of the ways that we're looking at doing much better is a concentration on survivorship. Most patients who are diagnosed with cancer in Ireland are cured. And I think that we lose sight of that sometimes. And I think that we need to, so things like long-term side effects of treatment, long-term issues for them in terms of sexual function that Eileen talked about are vital. Cancer is a continuum. It isn't just one point in time where you're diagnosed. You're diagnosed and either you go into remission and remain well and have to deal with long-term side effects, or where the cancer returns, and that this all needs to be dealt with. It's not a black and white area. And in England, there's a Cancer Survivor initiative where they're looking at 7 work streams assessing care, health and well-being, managing active and advanced disease, consequences of cancer and its treatment, financial issues, vocational rehab. And this, I think, is a fantastic development. And there's going to be a Livestrong project of 1,000 people to get them to tell them what's it like to be with cancer or living after cancer, to find out how we could do better. And one of the things we'd like to do in Cork is a cancer survivor clinic, where people who are 5 years or more after cancer diagnosis would come for one visit, and they'd be seen and assessed, and they'd get a health MOT, and then they would go with the prescription to their GP in terms of what needs to be looked at. That would do 2 things. It would allow us to get the patient to get an MOT of where they're at in terms of preventive measures, but it will also allow us to get an MOT in terms of how we could be doing better to deliver care earlier on in the illness. In much of what we do, the gap is the patient, because in our medicine base, when we're doing decisions, we talk about trials and research and molecular data, and then we treat the patient and we get data, and then we transfer care and go into evaluation of outcomes. But this is often a big gap, because often what we think is the reality for the patient is very different. Eileen has a much clearer picture of what my patient's reality is than I do, because she has more contact with them. And I think that would apply to many medical professionals. So how can we get better at that? Well, We can get that better at that through information technology and through simple time and listening. Information technology has the ability to transform what we do. If we just, when James Watson, the Nobel laureate, had his gene sequenced at the cost of millions, now we can get gene sequencing on a patient for $7,000, and that was last summer's figures. It'll probably have fallen by half this year because of developments in information technology. In global terms, 10% of the world's population are on Facebook. Facebook didn't exist 10 years ago. What will it be like in 20 years? And one of the things in England that they've done is they've looked at a project with smartphones for people on chemotherapy so that we can get a better handle of side effects. So patients are given a smartphone, it texts them every 12 hours, morning and evening, and they put in their side effects from the treatment, and that goes to a central register here. And if they're having too many side effects, that's a yellow card, it goes to a nurse. If they're having mad side effects or difficult ones, it's a red card, and it goes to a medical team on call. They also have a drop-down menu here of what do you do with the side effects. If you've got diarrhea, what do you do? The first-line treatment, second-line treatment, third-line treatment. And that allows them to have a database so they have a better handle of is this treatment making a difference? What's the patient's clinical reality like? And you could say to me, well, older people get cancer. So, I mean, so are you going to tell, how's your 80-year-old mother who's a potential cancer patient going to manage a smartphone? Well, what they've done is they've looked at Skype in the Western Isles of Scotland. So you could say many of us would have difficulty setting up a Skype link. I can't do it. So what they have is the patient sits down in front of a computer and opens the computer and puts on a scarf. And when they cross the scarf over, that activates a microchip which activates the Skype link, which allows them to communicate with the nursing service. And when it's finished, then they remove the scarf. And they have different scarves for different tasks. So that's for Skype. What about email, etc. So there's an awful lot can be done with information technology. The obstacle with information technology is people. This is a Canadian virtual hospice in Canada where there's remote areas, so it allows access to a virtual hospice to allow to assess people in symptom management. And you can email in, and they'll email you back within 24 hours about what to do. What about information technology in Ireland, where we have Intel, we have everything, we're the European hub, but we're not very good at information technology in our health service. But this is one thing, a good news story. It's robotic surgery in CUH. So this is the Da Vinci robot, and many of you may have seen the patient on the Late Late Show who came and had her surgery done the day before. And so this is, and Matt might talk about this later, but there's where the operators are remote. And I've seen some women with this after cancer surgery, and the recovery is phenomenal. And there's much smaller incisions to deal with. The recovery is more quick. They're hardly in hospital. It's a dramatic change which will make a huge difference to our patients. Advocacy has been discussed already, and I think that advocacy has an enormous role to play in improving cancer care. So if we look at the evolution of where we're going, when we started in the 1970s, the 5-year outcome with ovarian cancer was 15%. Now it's going to be 50% or greater with each of these advances in medical care. But that's just part of the story. It's not all of the story in terms of improving outcomes for people. If we think of who looks after patients, it's like we think about surgery and chemotherapy and radiotherapy as the primary cancer treatments, but that's not right. So, because there's more pieces than just those three main blocks. And John O'Donoghue, the writer, talked about harmony. He wrote the book Anam Cara, and he describes in the walls of iron that the walls have big blocks and little blocks, but the big blocks will fall down if the little blocks aren't there. So in the entire wall, to give for the entire thing, the small portions of the jigsaw are equally important to the large portions of the jigsaw. And in the team that we who look after patients, it's very important that we recognise that each part of this has a voice. But equally, a bit like the wall in the Aran Islands, without each of these points in it, it's not going to be as good as it should be. It's not going to be as fluent as it should be. The care of the patient isn't going to be as good as it should be. Many of us speak of the nurse navigator, people like Eileen, as being the glue that holds the wall together. But I think that's probably not correct. I think the patient is the glue that needs to hold the thing together. And I think that the patient needs to be more recognised as being part of the wall, because the care will be better as a result. And we'll end up with a landscape like this in the Aran Islands, where you can see that where it has achieved its purpose, where these small blocks have achieved a tremendous harmony. I'd like to thank you for inviting me to talk today and for your attention and for